So welcome again to our ACE peer learning session. We have a very special guest with us here today, Dr. Elizabeth Crouch. She's a Deputy Director of the Rural Minority Health Research Center and Assistant Professor in the Department of Health Services Policy and Management at University of South Carolina. And I'll let Dr. Crouch give any further introduction, but she's been a longtime partner of Children's Trust and has recently released an article sharing some information about ACEs and positive childhood experiences in urban versus rural environments. So very excited to have her share more with us today. So I'll go ahead and just pass it over to Dr. Crouch.
Hey, thank you all so much for coming to the talk. Thanks for being engaged. Feel free to stop me. Can you all see this without the notes view, or does it show notes?
We see the notes view.
Okay, what about now?
We're good.
Perfect. Okay, good. That's what I thought. That's good. I have two screens. You never know what's showing. Thank you all so much for having me. I've given this talk in various settings. We were at the National Rural Health Association conference last week in Albuquerque, New Mexico, and we gave a talk on positive childhood experiences. So this is one of my favorite areas to discuss. I think it's really important. And as I've worked with Children's Trust since, I guess, 2015 now, I've really appreciated the emphasis they have on prevention of ACEs and also implementation of PCEs, or positive childhood experiences. So ACEs, when I say ACEs, adverse childhood experiences, so you all know what that is. PCEs meaning positive childhood experiences. The main part of the talk today, I'll go over the ACE finding briefly, but we're really going to focus on positive childhood experiences just because it's kind of where the field is going, where we're looking at the flip side of the coin of resiliencies. I'm sure many of you all are aware of. I recognize some of you all from the home visiting world. So, like Dean, I know I've met you before. So anyway, thank you all again for having me. So I'm at the Rural Minority Health Research Center. This is located within the Arnold School of Public Health at the University of South Carolina. You see our mission up in here, are on there. We're hoping to both illuminate and address problems experienced by rural minority populations in the hopes that we guide research, policy, and advocacy. So those are our goals. If we go on further, we're going to be focusing on rural and racial ethnic minorities as health disparity populations today. But you'll see there's many other just vulnerable or populations that may experience some levels of discrimination or adversity right there. We're focused on rural and racial ethnic minorities today. Okay, so big deal is, why do we care about rural kids? So we've done some work nationally, South Carolina focus, which I'll share at the end of the PowerPoint, at the end of the presentation, but nationally, a little over 12 million children live in rural areas. My mentor, Dr. Jan Probst, some of you all have been in South Carolina a long time, may be familiar with her. She's like the matriarch of rural health nationally. We went to this talk last week and lots of people came just to hear her speak, not me, but to her. They all know her from her work. But she really cares a lot about kids, especially rural kids. So what are some differences between rural children versus urban children? So rural children have a higher percent of Medicaid coverage. They're more likely to miss at least one day or more of school. They experience higher rates of obesity, lower rates of preventative medical care and oral health care based on both insurance status and access. So the access point of lots of kids in rural areas live in health professional shortage areas. Recently, there's been an update from Dr. Probst and Dr. Zahn in our research center about higher mortality rates, largely associated with unintentional injuries, maybe lack of seatbelt use or farm equipment or things like that may cause mortality in kids, which is so sad. So what are ACEs? Who knows what ACEs are already? Raise your hand. Iris, do you know what ACEs are? I can't. There we go. That hand raised? Couldn't tell.
Yeah, Dr. Crouch, this is actually a group of ACE master trainers.
Perfect. Then I'm going to skip over the ACE part and get to Dana. Thank you for the context. Let me skip over the ACE part. Do you all know the differences in how they're calculated with behavioral risk factor surveillance system and the National Survey of Children's Health?
This might be helpful information for us.
Okay, cool. Dana, I appreciate you because I didn't have that context. This is very good. Thank you so much, my friend.
You're welcome.
So Prior work, so in South Carolina, for example, I'm sure you all have seen, since you're ACE trainers, the CDC, where we're using the behavioral risk factor surveillance system to measure ACEs, right? So we're looking at sexual abuse, physical abuse, emotional abuse, as well as some others. So substance abuse, mental illness, incarceration, those kinds of things. The way we're able to ask, and these questions can be traumatic, as you all know as trainers, we're asking adults to talk about their experiences. The data that I'm going to look at today, which is national in scope, looking at rural versus urban differences, is going to be using the National Survey of Children's Health, not BRFIS, which asks caregivers about their kids. So we're not going to ask invasive questions about emotional, physical, or sexual abuse, right? Because A, they're not going to report it if it's happened, and B, we also have some mandatory reporting issues, right? So instead, so that you got on this one side of the slide, you've got what the CDC asks with BRFIS. The other side of the slide, you've got what the National Survey of Children's Health asks. They ask, is someone home? Is someone suicidal in the home? Are there, or depression, alcohol and drug use, parent in jail, divorce, witness to domestic violence, which is all similar to what we ask in BRFIS. But we also ask about parental death, racial discrimination, and low income. The way they word low income is economic insecurity, and that's really important to rural because we have higher rates of poverty in rural by a lot. So that's kind of one of the things I want to distinguish is there's two different ways to look at this, and this is how we're looking at it today. Okay, cool. So we've had two papers published. We've had many papers published on ACEs and PCEs, but two looking at rural or urban differences. Both of these use the National Survey of Children's Health because we're asking. We also want to know, okay, so for policy intervention efforts, we also want to know, we care about what's happening with adults. Like, for example, for South Carolina, all we really know is what's happening with the adult population with ACEs, right? So we know that ACEs are intergenerational. You all know that from your work. However, how do we intervene today? We kind of need to know what's happening with kids right now as well, correct? That's important information. They're both important information pieces to have. What's happening to the adult, what has happened to the adult population in your area and how that might affect them as far as, health, physical and emotional health. But also we even know what's happening with kids. How we can intervene now. So we've got two papers that look at rural urban differences in ACEs and PCEs. I'm going to focus more on the PCEs, the positive experiences today, since you all know about ACEs, but I will go over how the adverse experiences differ. Okay, so in the first paper, we look at how rural children experience these select ACEs that we're looking at that differ from the ones maybe you all previously seen compared to urban kids. So rural children, as you're seeing, so rural's in garnet right here and urban's in the gray. Rural kids are experiencing higher rates of every single ACE except for neighborhood violence. And some of these are quite drastic. Like if you look at parental separation and divorce, if you look at economic hardship, parental death, household substance abuse. And we know that some of these, and I'm going to get to this a little later on with COVID, have been exacerbated, such as household substance abuse or substance misuse, where we know that substance misuse has increased a lot during the COVID pandemic, especially in rural areas. We've also seen higher rates of parental death during the COVID-19 pandemic among rural kids. So, okay, y'all yell out. Exasperated, I love it. Marie, yes, made me laugh. Jump in, my friends, because I'd rather this be interactive. I don't always see the chat with the Zoom share. So, Marie, yeah, exactly. It is exasperating as well as exacerbated, for sure. So, and we know a lot of these things went up during this. So, I do want to pause for a second. So, I do help evaluate the McBee program, which is maternal. Y'all know what McBee is, I think, maternal infant early childhood visiting program for South Carolina. But also, our research center is funded by a grant from the Federal Office of Rural Health Policy, and they have various projects that we, are asked to do each year. One of them this year, I think, is interesting, which I hope Michael invites me back after this, is that we're looking at differences in anxiety and depression pre-COVID and during the COVID pandemic using the same national data set, just because it's interesting to see. If there's any difference between A, rural urban kids and anxiety and depression, but B, also before and during the pandemic, as well as parental support. Because I know, for example, like I had a job where I could work from home, all people could not during this. but I had my kids home for like 5 months that year. So, and remote learning, et cetera. So that was a stressor because my husband could not pivot in the pharmacy. He cannot be filling prescriptions from home. So as a primary caregiver for a month, which lots of people were, but we were a well-resourced, had flexibility, et cetera, which a lot of people didn't have. So that parental support stuff is really important during this, as I know as you all do home visiting, ACE prevention work, et cetera. So some of that will be interesting findings I hope to present maybe you all next year once we get the data that this study done. Okay, that was random, but I think that'd be interesting for y'all. Okay, cool. So we also know that counts matter, right? Where 4 more ACEs are more, have a higher likelihood. Again, it's a higher propensity. It does not guarantee anything. We all know that's the case. Rural children are more likely to have 4 more ACEs than their urban counterparts. They're also less likely to have 0 ACEs. I think this is important, even though we all know a lot about ACEs already. Rural kids have a lot, often, not always, they have less resources or less access, more likely to be uninsured or underinsured, and they're more likely to live in a health professional shortage area. We know what that is. It means there's a lack of providers for both primary care as well as often even more so for mental health providers. So, and then same thing for adults. So how do you prevent intergenerational trauma? You need some interventions that work for both adults and kids, and how do we provide those without those resources there? So I think this is important stuff to kind of focus on for using. Y'all have the best tools, so I'm here to help illuminate some of the figures to y'all so y'all know the prevalence, but I need y'all to tell me programs and interventions that may be able to plug in and work here, because y'all know that better than I do. Okay, so in 2018, I went to Saratoga Springs, New York, and gave a talk to the National Advisory Committee on Rural Health and Human Services, because they decided 18 years after the original ACE study, they needed to focus on ACEs in rural. Y'all, we can only do so much, but it is very interesting because some of the problems with lack of funding for research for this, as well as there's data suppression for rural, which has always been an issue. They had recommendations, and then some of these recommendations have been taken up. So, for example, Federal Office of Rural Health Policy funded us to do an updated version of this study, and I'll show you all some of that. Am I allowed to go off kilter, Michael, later on and show websites, etc.?
Sure.
Okay.
Have at it. We're here to learn from you. Yep.
For further resources. So 2 things. I'm going to show our South Carolina ACE paper here in a little bit after the end of this. And then I want to show you all the Rural Health Research Gateway, because that's got some cool resources for how to do some of this on our own for South Carolina. Okay, cool. So let me keep going. So what are positive experiences? Okay. Has anybody heard of Bob Sege at Tufts or the HOPE framework? Oh, Dana's shaking her head. Awesome. So he has been one of the I think pioneers in this country right now of promoting positive childhood experiences and looking at the flip side of ACEs, right? Let's not just focus on the negative, let's also focus on the positive. So those of you, only a couple people shook their heads, so I'll go over what this is. These are positive life events, such as having a mentor, a safe, stable relationship. We're going to give some examples of these, because we know as people invested emotionally and time intensively into this field, we know that both positive and traumatic experiences matter for the health and well-being outcomes of our kids, right? And how our kids grow up to be healthy social emotional adults. Okay, so we know positive experiences may either prevent ACEs or mitigate or moderate the effect of ACEs, reducing toxic stress and promoting healings. Shockingly, y'all, I'm gonna go back for a second. Sege is doing this work. The quantification of positive childhood experiences has actually been quite limited. Again, who knows? So Christine Bethel at Johns Hopkins and myself at UofSC, we're some of the 2 people in the country right now that have quantified this and are publishing on it regularly, which is kind of shocking. I'll go over some of those citations here in a little bit. Okay, cool. What do we know? We know that identifying these positive experiences may help people to experience healing and recovery. We hope that programs that support these positive experiences promote healthy development while also avoiding stigma and labeling. There's a health equity foundation for the HOPE framework. The HOPE is Bob Sege's kind of acronym for Healthy Outcomes from Positive Experiences, where we're going beyond labeling individuals as helpless victims and figuring out ways to actually help people as a population as a whole. So we're focused on policies that may promote positive childhood experiences. And I believe that, along with Sege, that all this makes life better for all of us. Okay, quickly, y'all know these as people invest in this field. The 4 building blocks of hope. So one is relationships. This is for with other kids, with other adults, and through interactive activities. So having caregivers that respond to your needs, having adults outside of the household that take a genuine interest in child support and growth, and having healthy, close, and positive relationships with peers. That's the first one. The next one is environment. So safe, stable, equitable. So where kids have the opportunity to live, learn, and play in safe and nurturing environment. So that a child's in a home where the kid is safe, they have proper nutrition, they can get enough sleep. Their environment offers opportunities for high quality learning. So that's another building block. Engagement. Children, as y'all know, need ample opportunities for productive social engagement. So what are some examples of this? Being involved in projects, peer mentoring, community service, partaking in family cultural traditions. And one of the things I do want to emphasize is we go through how we quantify these, the National Survey of Children's Health. One of the deals is, y'all, we don't have, it's what this survey deemed was what this survey decided to ask about, right? So it's not completely culturally comprehensive, right? So there's some things in here we're going to measure that may be positive experiences for children living in a certain area, but other children may experience other positive childhood experiences that we weren't able to capture with this national data set. Okay. And opportunities for social emotional development. So developing, socially appropriate communication, interpersonal skills. A lot of this may arise during child-centered play, and these are critical for children to become resilient, healthy adults, right? So all this is important for growing up. Okay, here's how we quantify. We use 7 questions of National Survey of Children's Health to quantify PCEs. First being mentorship. Okay, one adult in this child's life who they can rely on for advice or guidance. That's not necessarily the caregiver. 2, family resilience. How often are your family able to talk together, work together, know your strengths, and stay hopeful? So this is a 4-question indicator from the National Survey of Children's Health. I think if you strongly agree on all of these, then you're labeled as having family resilience. Okay. Supportive neighborhood, same deal. Do you agree or strongly agree that people in your family, people in your neighborhood help each other out, watch out for each other's kids, and they know where to go for help? Similar questions for if a child is safe in their community. The social engagement, we've gotten some pushback from paper reviewers about this because they're saying this is, culturally not as inclusive as it can be, and I completely agree. This is a limitation of the data set. So during the past 12 months, this kid participated in a sports team. Do they have any clubs or organizations they participated in, activities or lessons? And during the past 12 months, did the child participate in any kind of community service or volunteer work in a school, place of worship, or in our community? So one thing I do want to note is we quantify positive experiences, PCEs, y'all. We're looking at kids 6 and older, so kids that are school age and above, right? Whereas ACEs, we can quantify that looking at kids from birth on. So for example, my husband's dad died when he was a child. He was 7, his brother was 5, and his sister was 2. So my sister-in-law would have had a couple of ACEs actually before she turned age 5. So this is an example of, so PCEs, because it's a lot of it's school age questions, we're looking at ages 6 and above. Okay, and sharing ideas. How well can you and this child share ideas or talk about things that really matter? Okay, this is kind of a busy slide, but this was using the 2017 and 2018 National Survey of Children's Health. This was accepted for publication, it's already out, in child abuse and neglect, looking at racial ethnic differences in PCEs. What we found, not surprisingly but sad, is because due to structural inequalities, in my opinion, this is why, we noted that minority children have lower rates of nearly every type of PCE, and also have a lower percentage of having 3 or more PCEs. So white children had the highest percentage in almost every category here of having PCEs, with their Hispanic counterparts having the lowest rate of PCEs, followed by non-Hispanic, Black, and others. So the PCEs, and I always try to say this in our discussion of a manuscript or a paper or in a talk, is they're not distributed equitably, right? They're not distributed, and these are not all in the household. So this is not purely a household issue, if you will. People might call it that, but it's a structural and community issue, right? It's our role as community members to help provide some of these to children in our community. At least this is, again, how I feel about this. Okay, PCEs in school, we also looked at with school success. So PCEs that may matter. Children, this is published in the Maternal and Child Health Journal. When it's not on this slide, because when I did this PowerPoint originally, it was under review, but it's now published in the Maternal and Child Health Journal. What we found was that children who repeated a grade were less likely to report all positive experiences except neighborhood safety. So what's that telling us? So children that have family resilience, less likely to report repeating a grade. Children that have a supportive neighborhood, less likely to report repeating a grade. So it goes on and on and on, right? Positive childhood experiences matter for academic success. If this is one way you're measuring academic success with repeating a grade. We also measured academic success with, so one is repeating a grade, which was the first slide. 2 is school absenteeism. Same deal. Children who experience school absenteeism, and this is measured as 14 days or more during the year. So that's almost 3 weeks of school. That's the highest count that the National Survey of Children's Health goes up to. So if you miss 14 days or more of school, you are less likely to report all PCEs except mentoring. So again, PCEs matter for school attendance as well. It's kind of the takeaway point of this part of the talk. Okay, let's look what's happening among rural kids. Rural gets a lot of crap for being, sorry, it's not an academic term, for being under-resourced, higher ACE count. We get a lot of negative feedback on rural, but rural has a lot of strengths. And I always try to highlight that when we're talking about rural, especially kids, because if it's a large, okay, so as I mentioned earlier in this PowerPoint slide or this talk, 12 kids, right? 12 million kids live in rural. That's bigger than some countries. We should care about what's happening in rural kids in our country. So rural children were more likely to have at least 2 of the positive childhood experiences measured in our adjusted analysis. They are more likely to volunteer in their community, and then more likely to have a mentor outside their home. And so volunteerism and mentorship are super important, and both these things were higher in rural versus urban. Now, this is published in the Journal of Rural Health. Currently, we were funded for more work on this by the Federal Office of Rural Health Policy. What we found there was, and this is not shown in the study yet, is among rural kids who had 4 more ACEs. So if you're a rural kid with 4 more ACEs, you are less likely to experience every kind of PCE. So, and that's the kids we want to have the most PCEs, right? If you have higher ACE counts, we want you to have as many opportunities as possible to build resilience and build healthy social emotional development. And what we found is, and then again, this is unpublished work. Well, it's published in the Gateway. It's not published yet, but it'll be published soon in the Gateway. I'll show you the Gateway at the end of this. But among 4 more kids, among rural kids with 4 more ACEs, less likely to have almost every type of PCE. Okay. So why do we study, we're going to look at next is within rural. So this was a paper published within the Journal of Rural Mental Health last year, where we looked at what's happening within rural differences, racial ethnic differences within rural kids. So we know that rural kids are worse off. We know that minorities in general were less likely to have PCEs. But what about people of color within rural, right? These BIPOC children. Black, Indigenous people of color, what happens with them? We know that rural BIPOC experiences these kids experience worse access and utilization of both mental and physical health services in their urban peers. And to make this even more important is the majority of growth in rural populations has occurred among people of color. right? So when we see growth happening in rural areas, it's often people of color, but because rural data is often suppressed and there's a small percentage overall of non-white rural children, they're often clumped together. So they're not able to look at differences. Most people are not looking at differences within racial ethnic differences within rural. So here's what we found. All the significant differences except for sharing ideas. So racial ethnic minorities, these colors kind of suck, I'm sorry y'all. The paler pink is Hispanic, middle color is white, the red color is African American or black, the last is, the garnet is multiracial. So what we found is racial ethnic minorities were less likely to experience each type of PCE than their white counterparts, except for sharing ideas with their caregiver. So again, we are finding these are not distributed, PCEs are not distributed equitably among rural and urban kids, nor are they distributed equitably among minorities, even within rural, right? So our SHOP, the Rural Minority Health Research Center, has been funded since the year 2000. Dr. Glover was the first person of color to receive tenure within the Arnold School of Public Health. She's worked closely, she's been in our center for 22 years, worked closely with Dr. Probst, my mentor, who I cited at the beginning of the talk. They were the first researchers to look at the intersection of rurality and race, knowing that rural people experience lots of population health disparities, and that structural racism on top of that basically, exacerbates as well. Maria, making your comment earlier, it's exasperating because they're receiving kind of dual disparity, right? So they're lower access and discrimination because they're rural, and they're also receiving the structural issues of structural racism and receiving less access to their people of color. So that's why we care about looking at racial ethnic differences within rural. So what's happening in South Carolina with positive experiences during the COVID-19 pandemic? And we have not updated this data since 2021, but this is what we have so far. So McBee, everybody knows what McBee is, right? Would you raise your hand, please? Well, not raise your hand. Thanks, friends. Okay, cool. So mid-March 2020, a lot of visits went virtual. At present, some sites are virtual, some sites are hybrid, some sites are completely in person. It varies greatly based on where you're at in South Carolina for home visiting. Let's look at some of the benchmarks comparing 2019 to 2020 and what's happened. So maltreatment rates, this is usually where I give a de-identified, or I give a data set to RFA, which is the Revenue and Fiscal Affairs Office, which handles big data for South Carolina, with kids' social security numbers, etc. They send me a so I send an identified and say, how many DSS reports do we have for maltreatment? They send it back to me as a de-identified, just count number. So I don't know who it is, but I know what the maltreatment rate is. And so for 2020, there was 37.4 investigated cases of maltreatment per 1,000 kids. And it's a marked decrease, 37.4 from FY19 of 90.9 cases per 1,000 children. So we're suspecting that maltreatment has not gone down. I actually would hypothesize that with all the time we've had at home, all the stress of lack of childcare, schooling, work flexibility, loss of jobs, etc., that's actually increased during the pandemic. We suspect there are just fewer reports of child maltreatment due to the COVID-19 pandemic. So that's one. Parent-child interaction. This is another thing we measure with McBee, looking at who received an observation of caregiver-child interaction. It was only slightly lower. The difference is pretty small. We think the home visitors are making the max use and excelling as much as they can with the use of virtual settings to see how parents interact with their child. We're thankful for home visitors. They have a really hard job and are doing it well even in the midst of the pandemic. Language and literacy. Percentage of children enrolled in home visiting with a family member who reported that during a typical week, the child was read to, told stories, sang songs. That performance measure reflects an improvement over FY19. So some things went down and some things were worse. Some things were better, some things were worse. Okay, some of these I'm going to go through kind of quickly because I think some of you all know them. How do we overcome ACEs and PCEs? Have you all heard of some of this stuff before? I'm guessing in your work as train the trainers and your personal work. The CDC's recommendations of some Brooks shaking her head, yes. The CDC's recommendations for reducing ACEs. I just applaud the work you all are all doing. This is incredible. Most people are very engaged in strengthening economic supports for families, parenting programs, connecting youth. All of the things we know improve ACEs, improve the reduction of ACEs, and improving PCEs. So I'll kind of move through that since some else people shook their heads and they know about these CDC recommendations already. Home visiting programs. I love home visiting. I think it is amazing work. Parenting education, so strengthening families. Programs at Children's Trust always intervenes. I was on a podcast today, Michael, for I'm going to show you all the World Health Research Gateway in a second, where we had some work come out from the Federal Office of Health Policy that was approved. So they have the World Health Research Gateway is a podcast. Anyway, I said Children's Trust of South Carolina. I can't say enough good things. They're doing so many wonderful things in our state. We're so thankful. So including implementation of many of these programs. One thing that is very, I'm going to get into in just a second. I'm going to get to the substance, but I don't think it's in this talk, so I'm going to do it here actually. Rural communities have higher rates of substance misuse, especially with opioids, and lower rates of access to treatment. So that is one of the things that has gone up. We know opioid use has gone drastically up during the pandemic. We know rural suicides have gone up during the pandemic. And we know that rural kids and rural adults, due to health professional shortage areas, have much lower rates of access to mental health care professionals. But they also, not only mental health care professionals, but providers that will prescribe buprenorphine, alternates to opioid use. So and I just want to say that's another thing to kind of caveat is there's a professor at UofSC who's in the next door to me, I'm at the research center right now, but on campus, which is like 3 blocks that way, who solely focuses on substance misuse. She's gotten several huge grants, $5 million plus grants to look at substance misuse in rural. And one of the things she's doing and her group is doing is basically data scraping. So they're figuring out what does Medicaid actually cover from these states, and what do they do for rural communities, and then what rural providers, so like what's covered by insurance, and then which rural providers are actually able to prescribe or feel comfortable prescribing some of these alternates for substance treatment. So community initiatives, we always promote the SEEK program, where we're helping families get connected to their primary health care providers to community supports. I always give a shout out to Julie Smithwick's shop for community health workers in Pasos with Mike. Some of y'all know Mike from the consortium. Who is doing this research? To where, Shanada? So you tell me, you mean like the last bit, or?
Shanada.
Shanada, I'm sorry.
No, you're fine. The professor that you just mentioned that's doing their research.
Oh yeah, Christina Andrews. Look her up. She's awesome.
Awesome. Thank you.
Yeah, ask away, my friend. Sorry, the chat is hardest sometimes for me to see, so my apologies. Compassionate Schools. Am I familiar with this? I love Compassionate Schools. I went to a training right before the world shut down that Friday before. Dr. Mira went with me from our shop, and she said, well, Elizabeth, the world's not going to shut down. You're going to come back to work on Monday. And I was like, oh, I thought they're not going to shut down. I didn't think we didn't know how bad COVID was yet. But we went to this train the trainer for Compassionate Schools, and I learned a lot about it. How do I learn as a researcher? How do I learn what's relevant and topical? I go and hear people like you all speak, right? I hear what's happening in the community, what's happening in programming, and I learn what some of the needs are, right? That's the only reason this research is even relevant or helpful is if we know what's happening on the ground. So this is really cool because it talked a lot about how kids who've experienced traumatic events, some of their presentation from trauma, for example, may present as ADHD. So you may have some erratic behavior because you don't know, because you've not been able to have ways to cope and have mindfulness, etc., and with trauma. So some of the stuff I learned from this 2-day training, I learned it's helping my own kids, right? My 5-year-old, I'm like, let's take deep breaths. Let's sit away for a second. Now, I'm not always the best because I also lose patience as a parent, especially during the last 2 years when we're isolated from everybody else. But some of this has been really helpful for me, and I always kind of advocate for them because I think it's awesome. Okay, and you all know statewide resources for this and ACE initiatives. Okay, so I'm going to go off kilter, Michael, for a second, and I'm going to stop my share, And I'm going to share with you all some resources that I think are really, really good that have helped me learn more about rural kids. Okay, so let me share screen again. All right, is that showing the gateway? Or is it showing my picture of New Zealand? Perfect. All right, cool.
Yeah.
Thank you for the thumbs up and the nod. Okay, so the Rural Health Research Gateway, you can look up our shop. Did it go to the next website for y'all? I never know. When I teach, sometimes kids are like, Dr. Crouch didn't show the thing you're talking about, you're not showing your screen. So always tell me to stop. Okay, so you can look at our current research. One of these, or you can just look on the rural urban differences in adverse and childhood positive experiences. And we've got the first brief out from this. Does that show? Is a brief showing y'all? Or still the website?
We can see it.
Perfect. All right, cool. So this is the updated work where I presented you all this public use data. This shows the most recent data where we go to the research data center up in Raleigh. We usually have to go in person. During COVID, they let us do remotely, which was huge. But we want to see what's happening in all 50 states. And some of these, what's kind of depressing from this is you can scroll down and look at this. If you compare this figure to what I showed briefly a few moments ago, where we looked at rural urban differences and adverse childhood experiences, the magnitude of some of this stuff, like economic hardship, for example, it's greater than a 6% spread now. If you look at all 50 states, it's much bigger. So some of the results, the direction of the results didn't change. The rural urban differences still existed, but the magnitude changed, right? When we were able to get access, so let me back up. When we use a public use data set for rural, they never show all 50 states because they're like, oh, some states have a small percentage of rural, and they'll affect confidentiality, blah, blah. So you don't get all 50 states. So that's why you have to go to this research data center and get restricted data sets. And it's important because we get a full picture of what's happening in all 50 states, but also I think it's really important, like, for example, when I gave this talk in Saratoga Springs, New York to the National Advisory Committee like 5 years ago, they were like, Elizabeth, what's the deal? Like, what happens with American Indian and Alaska Natives? Like, what happens in tribal communities? Like, what's happening to those kids? We had no idea because they were data that was suppressed because they lived in these like North Dakota, South Dakota. You all can get some of that, right? Not all, but a lot of them. We also have tribal people in South Carolina and North Carolina, but it's a small percentage compared to these other swaths where it's completely missing data. So we want to know, what's happening in all 50 states, but also these racial ethnic differences, right? Can we look at American Indian and Alaska Natives, for example, which we couldn't look at using the public use data set. So let's scroll down to, then we present it here, we present it, maybe giving away for these are short, okay, yeah. So this was the first brief that FORP has they have to go through approval process. So one is adverse childhood experiences by type. The second is PCE's experiences by type. Same deal, a lot of these relationships still held, but the magnitude changed. So for example, you see rural children much less likely to experience after school activities, but much more likely to experience community volunteerism. And that's it for this brief. So the other briefs, so for example, we've got 2 more briefs coming out from this funded work. One was looking at racial ethnic differences within ACEs and PCEs, and that has not yet gotten approved by FORP, the Federal Office of Rural Health Policy, so it's not yet on this Rural Health Research Gateway, but I'm going to give it away to y'all what the results were. So the American Indian Alaska Native population had much, much higher rates of ACEs and much, much lower rates of PCE. They were actually the worst. They were actually the worst group, that was like the worst off from all the groups. Again, I think it's because these ACEs and PCEs, occur not only within the household but also within the community structure. And some communities we know have had, historical trauma or structural trauma. Okay, cool. And then we also looked at among 4 more ACEs, what's happening with their PCE count. And I discussed that earlier in the talk. We talked about, with kids, among rural kids with 4 more ACEs, they were less likely to have nearly every type of PCE except for one that was mentorship. So there's some positives in rural, and there's also some things we still need to work on. Next, I want to stop share for one more second and pull up papers so you know where to look if you want further information. Let me pull up.
I know you're on a roll here, but at some point, if you could stop and just share a little bit more.
Oh, sorry.
I know you mentioned about how those particular positive childhood experiences were selected, or why those are the ones that were asked about. Could you say a little bit more about what you know about those particular questions and why those are the ones we've been focusing on so heavily?
Yep, let me pull up. I'm going to pull up another resource so you can see it. 1 second. Okay, yeah, that's a great question, Michael. My apologies. 1 second. Okay, I'm going to share screen again, y'all. This is the Maternal and Child Health Journal, where we look at, so you can see what the paper is, positive childhood experiences promote school success. Let me zoom in on those questions. These questions were chosen, my co-authors and I use the HOPE framework. So we use those 4 building blocks. They're all there now. I think you can see them all now. We use those 4 building blocks, Michael, and we said, okay, which questions from this national survey fit into each of the building blocks, right? So in our method section, I'll go into that in a second, you can see where we've put, like, for example, safe, stable relationships, where that was mentor for advice, share ideas with a caregiver, those fit into that block, right? Opportunities for peer engagement, volunteering, after school activities. So each of these we felt like fit into a block, one of those 4 building blocks of HOPE, based on what questions were available in this data set. I do want to say again that the data set is limited, right? Because some of these are not culturally competent for all groups, nor are these provided in all groups. So for example, after school activities, in rural, there's much less opportunity for after school activities just in general, right? But there's a lot more opportunities for community engagement in other ways. So I think in the method section, yes,
Yeah,
as a
that's super.
PCs,
Go
what'd you
ahead.
say?
I was going to say that, yeah, that's super helpful. I know you kind of mentioned that, but that's one of the most common questions that we get at some of our trainings, is even on the ACE questions as well. We can kind of explain the ACE questions, why those were chosen, but for the positive childhood experiences, since they're sort of a newer area of study, sometimes it's harder for us to know exactly, but it's good to know they're from that national data set and they fit into that HOPE framework. I think that's pretty in line with what we've said. Dana, is there anything you would add there about when we talk about positive childhood experiences? A lot of times Dana is the one that's talking about these experiences too in our training.
No, I think that gets to the questions. I have a different question. I don't know if now is the best time to ask.
Go ahead, yeah.
Okay, so we know that positive childhood experiences can negate some of the effects of adverse childhood experiences. Do we know, has there been any research done to show kind of overlays the presence of adverse childhood experiences, the presence of positive childhood experiences, and then outcomes for adults?
Not yet, which would be
Okay.
very interesting. Yeah, let me see.
Yeah.
Hold on 1 second. I want to share something that's not yet out. Hold on 1 second. We have. Okay, let me remember. My memory's bad on this. Okay, yeah, okay, now I know what this is. Okay. Remember, let me share recent research. Okay, so South Carolina got funding from Blue Cross Blue Shield Foundation, I don't know, 4 or 5 years ago to collect positive childhood experiences. Have y'all heard that before? And so information with the behavioral risk factor surveillance system, we just got it for 1 year, so we got it for 2019. I've done 1 paper on that. I hope to do some more work this summer because I'm done teaching, et cetera, and things are a little bit calmer. But we're looking at the adult population, and this is, again, these are different PCEs that are measured in the National Survey of Children's Health of Kids. So let's look at that in just a second. But we want to understand racial and ethnic differences and whether it differs across groups. We did not yet look at outcomes, for example, Dana, of what happens to them long term, like, you know, smoking exacerbated illness, binge drinking, all these things that we know for overall physical mental health. So let's go to the tables real fast. so we can see, remember, I don't think this is out yet. It's in the Journal of Child and Adolescent Trauma. That's a journal. Okay. These questions are different. These were the positive childhood experiences included in the South Carolina Behavioral Risk Factor Surveillance System in 2019. So, and these were based on data that the questions that the Wisconsin Children's Trust, Children's Trust of Wisconsin, I can't remember the name of it, the official name is, but it's basically the same organization, similar name, that they ask in their purpose survey. So, how much of your childhood was there an adult who made you feel safe and protected? Did you feel you belonged in high school? Did you feel supported by friends? How often were there at least 2 adults who took a genuine interest in you? How often did you feel like you had family to talk to about your feelings? I like this one a lot. How often did you participate in your community's traditions? Right, it's different. It's kind of getting some of those cultural things. How often do you feel like your family stood by you during difficult times? So, and here's what we found. This is the demographic table. These were significant by race for safe and protected, belonging in high school, and supported by friends, where we again see, well, actually, non-Hispanic Black had higher rates of feeling safe and protected than non-Hispanic White or Hispanic. Belonging in high school, non-Hispanic Black was highest, followed by White, followed by Hispanic. Support, and by the way, the bold of it means it's significant. Supported by friends, highest by White, followed by Black, followed by Hispanic, and then the family stood by you in difficult times. This was highest by White, followed by Hispanic, and then non-Hispanic Black. So this was just a purely descriptive table. We also did some regression analysis, which just means we not only, so bivariate, it means we just looked at simple categories, comparison of categories. This multivariable regression analysis means we're just controlling for stuff. That's just a fancy word for saying we control for a bunch of crappy things important, like gender, age, education, and income, right? And what we've seen is lower rates of education among the people that responded meant they were less likely to experience these PCEs. So we know that poverty or economic insecurity is an ACE that does affect your ability, that seems like to be your ability to receive some of these PCEs. And again, poverty was important for people making less than $25,000 a year. So I'm trying to think what else that would be important from this. So yeah, we go through how these were selected. Let's see, we talk about this one gets less into, we use the Wisconsin Children's Trust, but we still use the PCE framework, right? Which questions fit into which category bucket. So the HOPE framework is how we're selecting these questions. I didn't have a hand in selecting these questions for Burfus. I believe this was back when Melissa Strompolis was still at Children's Trust and Oddity and Servasta, and so they were they used the Wisconsin one, which works. I mean, it's just a different survey question, and I think honestly, it's good for certain questions to be asked of adults and certain questions of kids, because adults can answer maybe different questions or things that they might have. Children, caregivers asking about kids' belonging may be a little bit harder to understand, right? Versus adults do get that. So, what other questions? Jump in, please. And I talk fast. I'm sorry. But those of you that know me know that I just get excited about this work, so that's part of it. But interesting next step research questions would be to look at what's happening with PCEs and long-term outcomes in South Carolina adults. And I'm going to write that down.
Something else that comes up a lot in training, I'm sure it will continue to come up until we can just erase COVID from our language. But, what data or is there any data that you could point to that shows how COVID is having an effect on these positive childhood experiences or ACEs?
So the only thing is that we are funded by the Federal Office of Rural Health Policy to look at anxiety and depression among kids and how that's changed during COVID. But positive experience pre and during COVID, we have not yet done. I think part of the reason is the data that's available is the latest data says the 2020 National Survey of Children's Health. 2020 Burfus hasn't even come out yet. So I think there's always a data lag of a year or two. So sadly, we can hypothesize some of these things. Like we know that because of lower vaccination rates among rural communities, we saw higher rural deaths, and we saw more rural children losing caregivers than their urban counterparts for that reason. But we don't know beyond parental death how, for example, parental stress, I would hypothesize it went up during COVID, but I haven't, just anecdotally, but I've not been able to quantify that yet. So I think in a year or two, I'll be able to come back and show you all some more information about what's happening pre and during or post pandemic.
That's great. And I wasn't even thinking about this too, but I imagine some of the data collection and normal processes probably were even slowed down by the pandemic as well. So it might be even a longer lag than normal for some of that data.
That's the sad part. Yes.
Yeah.
It'll be interesting to see the correlation between what's happening with our childcare industry post-COVID, through COVID and post-COVID, and how that may impact the positive childhood experiences that are occurring outside the home, that social emotional development.
Oh, yeah.
Because the kids are totally missing out. They don't have the providers that were there. They don't have access to safe and equitable childcare for their children. At least that's what we're seeing with our clients with Nurse Family Partnership. So it'll be really interesting to see how the PCEs are impacted by what's happening in the childcare industry.
Yeah, I just can't imagine, we're all under stress, and then you're under stress of at least, I have a 5-year-old and a 2-year-old, so I do understand some of the minutiae of this. Our 2-year-old was like 5.5 months of the world shut down. So how do you, employ people in a childcare setting when it's high risk, lower pay, and a lot of stress, right? We had a lot of closures, shutdowns. I mean, all of that is very stressful for daycare directors, right? Who are often have very good intentions and good hearts, but just are in a very, very stressful job during this. I mean, I told that to my son's principal this year for kindergarten. I was like, I would not want your job right now. People are mad if you mask, mad if you don't mask. There's no good answer to this, right? The appeases the whole crew, and keeps everyone safe. So yeah, this is hard.
Dr. Crouch, can you please share your email with us? I'm interested in some of the research that you've been collecting and would like to know more about the cross between ACEs and PCEs.
Sure. My email is right there. I'm happy to share anything I've shared today with y'all. And I sent the PowerPoint to Michael, who please share this with everyone, and please feel free to reach out.
Sure, yeah, and thank you again, Dr. Krause, for sharing with us today, and for all of you for your time and attention. I will be sending a PDF of the PowerPoint as well as a link to this recording for our friends who aren't able to join us. I should have pulled these dates up before the end of the call, but let me just pull up when the next peer learning session is. And also need to mention that our Building Hope for Children conference is coming up August 24th and 25th. Registration is now live on the Children's Trust website. Our next ACE peer learning session will be focused on resilience. So we'll have someone come and talk a little bit more. Typically that session is more focused on strategies. This session is the data session. Dr. Crouch will kind of go through the neurosciences of the ACE presentation, which are neuroscience, epigenetics, the ACE study, and resilience. And so the next quarterly peer learning session is September 15th. So mark your calendar for that. And just a bit of personal news, I have accepted a position outside of Children's Trust. And so this will be my last quarterly peer learning session. But I really appreciate all the work that you guys are doing and will continue to do. My last day will be May 27th. I'm leaving you in the great hands of Dana, Alexis, and many other staff at Children's Trust. So just thanks again. Any other questions or comments before we close out for today?
Last question for me.
Okay.
Is there going to be another adverse childhood experience train the trainer, or have those been fulfilled for the year?
Dana, you want to take that one?
There are many more adverse childhood experiences training of trainers coming up. We've got a grant with the Department of Education. And so right now we are in the process of doing about 1 TOT a month that's really specific for school employees. And that can be administrative staff, teachers, or behavioral health folks, school counselors. So we're doing those right now. We've got one also, I think, coming up with the Department of Social Services. But if you have folks from other areas that are interested, we are, we can't guarantee, but we may have some spots in our DOE TOTs coming up if you've got some folks from outside the school that would be interested in participating.
Awesome. Thank you.
You're welcome. About 4 years ago, we did 1 TOT a year, and now we are at probably 12 to 15 a year. So there's a lot happening.
Yep. Anyone else have any questions? Brooke, Iris, Lyle? See, you came off camera. Nope, we're good.
I'm good. Thank you, Dr. Crouch, for your information.
Thank you all so much for joining in. This is great.
All righty. Well, thank y'all. I hope you have a great rest of your afternoon.
Take care, guys. Thanks.
Bye.